Hello friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. All right, friends, welcome to episode 17 of Sterile Field Guide. In this episode, we are going to continue talking about anesthesia. In the last episode, we talked about some intravenous options for induction, such as propofol and etomidate and all of those fun things. So if you missed that episode 16 is chock full of information about the basics of anesthesia, as well as some things that you probably want to know as a budding surgeon. So check that episode out. In this episode, we are going to talk about inhalational gases and the concept of MAC, which I thought was pretty confusing when I started my anesthesia rotation. And so I feel much more in tune with what's happening in the OR now that I know what the gases are doing. And maybe if I smell something funny, I will know what's happening. And so there are inhalational gases that actually play a really big role in anesthesia. And these gases are titrated to something that's called MAC. And MAC stands for minimal alveolar concentration. And the MAC is something that has been calculated and studied a whole lot. And the minimal alveolar concentration, or MAC, is where 50% of the population does not respond to things like verbal commands or surgical stimuli. So that is a specific kind of MAC. There are different kinds of MAC. There's MAC awake, MAC aware, and MAC blunt autonomic reflexes, or MAC bar. MAC bar is the MAC that we are targeting in the OR. This is where patients are not going to be responding to surgical stimuli. And so that's what we're going to be targeting. We don't want patients to be awake but not responding to verbal commands. Really just don't want patients to be moving around when we're performing surgery. And so the MAC bar has been assigned a value, which doesn't matter if you remember this, but the MAC bar has been assigned a value of 1.5 to 2.0 MAC. And what the heck does that even mean? Good question. What the heck does it mean? I was also very confused. But essentially, these different gases have been assigned values, their MAC percent. Assigned is not the right word. There's a lot of physics and a lot of testing. The MAC is assigned to each gas based on its partial pressure at sea level, and other factors of the gas are important to consider, like the solubility in blood, the solubility in lipid. Those sorts of things sort of play a role in how quickly and how effective these gases are at inducing anesthesia. Essentially, for basic introduction, these gases have been assigned their MAC percent, and then these are going to be sort of based on the solubility and the partial pressures and those sorts of things of these gases. And so you will sort of calculate the percent of the gas with the volume of the air that you're giving, and then they add up and they are supposed to equal 1.5 to 2.0 for MAC bar. That's a lot of information, but essentially anesthesiologists are doing math back there, so respect them and be nice to them. There's real life math happening in that room. Some physics too. It's pretty crazy. So the MAC of some commonly used gases. So commonly used gases are isoflurane, sevoflurane, desflurane, and nitrous oxide. You've probably heard of nitrous oxide or laughing gas before. The MAC of these different gases are: isoflurane is 1.2%, sevoflurane is 1.85%, desflurane is 6%, nitrous oxide is 104%. So some people just settle for 100% with the nitrous oxide. But again, like I mentioned, you actually have to do math to figure out what MAC is right for your patient. And we won't necessarily go through the math in this episode, but just know that you can figure it out. And I can post the equation on the Instagram so that you can sort of peruse if you're interested to see what they're doing. All you need to know is there is a titration of gases to achieve the right concentration to keep somebody sleeping. And so how do we measure the MAC? This is something that I was really confused about as well. So there's ways to monitor this to make sure patients are getting what they need to get. So when you look at the endotracheal tube or the ET tube, there are typically two plastic tubes making up that circuit. One of them is going to be delivering air that has the gases in the circuit, and one of them is going to be receiving the exhalation from the patient. And so you can measure both what you're delivering and what you are receiving from the patient, and sort of the process, or like the journey of this air with the gas in it. It's going to enter your lungs, and then the gas that's going to diffuse into your blood is going to diffuse into your blood, and your blood's going to carry that to all these different tissues, and your tissues are going to take up a little, and this tissue and that tissue or whatever. But the tissue that you really want to take it up is your central nervous system. So on the way to the brain, different tissues are going to be taking up this gas, and then whatever's left when you get to the brain is what your brain is getting. And then that blood is going to venously drain back to your heart, back to your lungs, and you're going to breathe out whatever is left, whatever's going to diffuse back into the alveoli. And so all that to say, when your inhalation, what you're delivering and what you're receiving are the same, that's when you know that you've like sort of reached your max for that patient. And I mentioned like, okay, it's going through these tissues, and this tissue's taking it up and that tissue's taking it up, because when things are super soluble, that actually makes them slower at induction. And I thought this was confusing, and I was like, how can something that's like more easily taken up be slower at induction? And the tea about that is, because it's so easily taken up, it just gets distracted on the way. This is obviously not like the physics math way to explain it, but as it's like going through your arteries, through all of these different tissues, it's so easily taken up that before it gets to your central nervous system, it's all been sort of like used up. And so you're only getting a little bit to your central nervous system, and it has to share with a lot of places. But if it's like slower to be taken up, it's just easier to get it to the concentration that you need for it to like stick around. You can also think about this in terms of the solubility of the gas itself. If it's super soluble and the blood or the tissues have a really big tank that can accommodate a lot of that gas, it's going to take a lot longer to get to the concentration that you need, because it's so soluble and your blood can hold so much of it. That might be confusing. There's a lot of videos about this. I don't know that you need to like totally understand the physics of it right now, but that is something to sort of start thinking about. Okay, so talking very briefly about the different kinds of gases. So nitrous oxide is one that you're probably pretty familiar with. This actually cannot be used alone to put you to sleep. It has to be used in conjunction with other gases. It doesn't cause any relaxation of your skeletal muscle like the other gases do. Importantly, nitrous oxide works on the NMDA receptors in part. And some side effects of nitrous oxide is it can sort of seep into any place where there is air. And so places where there's air is like in your middle ear, in blebs if you have COPD, in your bowel, in a pneumothorax, for instance. And so if you have a known pneumothorax, nitrous oxide is probably not your best friend, because it can sort of seep into that place, and it's much easier for the nitrous oxide to get in than it is for it to get out. And so you can cause a worsening of a pneumothorax. You can also pop blebs or make them bigger and those sorts of things with the nitrous oxide. So just some things to keep in mind with that. Long-term use can also cause pulmonary hypertension. Long-term use of nitrous oxide can also cause pulmonary hypertension. Sevoflurane is the next gas we'll talk about super briefly. 2 points, smells pretty sweet, and can be used for induction on its own. Isoflurane, the next one, is really stinky, and it causes vasodilation, decreases your blood pressure, and can increase your cerebral blood flow, meaning that it can also increase your ICP if you use it at above 1 max, which is not as severe as other gases, but isoflurane can increase your cerebral blood flow and your ICP. Desflurane is the stinkiest. It has a low solubility, so the fastest induction, but it's really, really stinky, so you can't use it for induction alone. Patients don't love it. It's like stimulating and nasty. So that one is not typically used alone for induction. For gases in general, just going through some of the things, we typically think of gases as vasodilatory. So if you're going to be giving a gas, you probably are going to have some hypotension, some decreased systemic vascular resistance. That is sort of a thing that we expect with gases. There are like specific things for specific gases. I don't think it's necessarily imperative that you know all of the things, but these gases can also increase your heart rate, which can increase the stress on the heart, cause increased myocardial oxygen demand, which is not ideal for a struggling heart. And all of these gases, important to note, can increase the risk for post-operative nausea. And so if post-operative nausea and vomiting is something that you are really concerned about, you can do something called a TIVA, or total intravenous anesthesia. And this has a decreased risk of postoperative nausea and vomiting, and you can use it for other reasons why you maybe wouldn't be able to use the gases, like for instance, malignant hyperthermia, which we'll talk about in a second. You have an increased risk of awareness under anesthesia with a TIVA. Patients can sort of wake up. The gases are really good at keeping people asleep. You really have to titrate their intravenous medication. Your IV can slip. Your IV cannot be flushing as well as it needs to when you're doing everything through the IV. So you ought to be doing some intraoperative monitoring to help make sure that when the patient is paralyzed, they're not awake and not able to tell you that they're awake. And so some of these things use basically like process EEG data to sort of tell you how awake the patient is. And so these are things like SED lines or BIS monitors, but these are basically like process EEGs that help you determine if the patient is awake or asleep. These can sometimes malfunction, and so it's not an awesome idea to just write off a malfunctioning SED line or BIS monitor when you're doing a TIVA because you don't know if the patient's awake or asleep, and just like paralyzed and unable to tell you. So that can be really scary for patients. So trying to decrease the amount of awareness under anesthesia, I think your patients would be really grateful for that. But I also think that it's important to understand like different patient populations, like especially trauma patients, have an increased incidence of awareness under anesthesia. And so just trying to like be mindful of those things as you think about your anesthesia plans for your patients. All right, so we talked about one reason why you might need to do a TIVA or total intravenous anesthetic. Another reason is if a patient has or is susceptible to malignant hyperthermia. So malignant hyperthermia, you may remember, is caused by a defective ryanodine receptor. This causes increased muscle contraction secondary to sarcoplasmic calcium release. And this can be caused by a lot of medications that we give in the operating room, such as inhaled gases like sevoflurane, desflurane, halothane, and succinylcholine, which we talked about in the last episode. And so if you have had a history of malignant hyperthermia, obviously these drugs are going to be avoided in you, but also if you have a family history of malignant hyperthermia, if somebody really closely related to you has had malignant hyperthermia, it's likely that these drugs will be avoided in you as well, even if you have had general anesthesia, like an inhaled gas in the past, and not had it. It is still possible for you to develop malignant hyperthermia, and this can be like a terrible thing for patients to undergo and can have sort of like high morbidity. And so we don't want patients to have malignant hyperthermia, so obviously we're going to avoid those drugs if we can, and we know. There are two different like stages of malignant hyperthermia in what you can observe as a clinician. So there are early signs and late signs. Early signs are going to be things like tachycardia, tachypnea, and muscle rigidity. You'll also see hypercarbia, so you'll see their CO2 sort of build up. Late signs are going to be hyperthermia, EKG changes, and myoglobinuria. Those are sort of like the stages of the malignant hyperthermia to be aware of. And then when we're talking about treatment, we know that dantrolene is the treatment for malignant hyperthermia, and then supportive treatment like cooling the patient. But dantrolene works by blocking the ryanodine receptor. We know that the ryanodine receptor is defective in this setting, and so blocking that receptor, stopping offending medications, providing supportive cooling like cooling blankets can be helpful, and then increasing minute ventilation to help with the hypercarbia can be helpful as well. All right, and that is going to be our introduction to inhaled gases and MAC anesthesia. This is a little bit of a shorter episode than last week, but I hope that you enjoyed it and that you learned a lot, and I will talk to you next time. Bye! That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.